We're going to start off with a review of endocrine physiology, and then we can kind of talk about what happens when that physiology goes wrong. So, endocrine system, what is it all about? This is a very, very basic review. I'm sure you're comfortable with it. We'll just go through it quickly. So, your body has two ways of coordinating activity, right? The nervous system and endocrine system. Nerves are good for quick end-to-end communication, but if you want to talk to every cell of the body, it's just not possible. It's not efficient. And so, the endocrine sort of takes up that duty, that role for our body. Every living cell has a receptor that it can sort of interact, get a signal from, and transmit that signal into the cell and change the functioning of the cell down the line. Receptors are picky. So the type of signal that they respond to is typically very selective. And so some receptors are unique to a certain cell type. Some you're going to see on a variety of cell types. The example I like to use is insulin. Insulin receptors are on many different cell types, everything from muscle to fat to bone to liver. Insulin is really going to be communicating with a lot of different types of organs, and you can compare that to something like parathyroid hormone. Parathyroid hormone is important for regulating calcium levels, and so parathyroid will work at the bone. Parathyroid hormone will work at the kidney, and that's about it. Those are the only two places it'll respond. So some receptors are going to be very promiscuous and going everywhere, and others will be very monogamous, I suppose. In various parts of your body, there are organs that produce and store hormones. Hormones activate receptors that cause examples to work differently. So our example here, eating a donut and washing it down with soda, part of a keto diet probably. It's broken down in your GI tract. You absorb it as carbohydrates, ends up as glucose in your blood. The pancreas, which is our endocrine organ, is able to detect an elevated glucose level. It starts to secrete insulin. That insulin will interact with receptors on fat cells, on liver cells, on muscle cells, and stimulate them to absorb glucose faster. That will cause a drop in glucose level, of course, in the blood, which will have that counteracting mechanism to stop the pancreas from secreting insulin. And so the endocrine system is really all about checks and balances, about feedback and negative feedback, and making sure that we don't sort of drive our car over the cliff when it comes to responding to these different changes. Feedback. Gets too cold in your house, what do? Turn up the heat, right? Now it's getting too warm. What do? You go back and turn the heat back down. Our body's going to work in the same way. Any changes from the norm, any changes from our homeostasis, we're going to utilize hormones to bring us back to the normal level. So let's sort of work through an example here. Okay, so let's just look at the top here. So here we have some center of our brain that is able to detect, say, we're walking out into the cold. You live in a pretty cold area, don't you? Aren't you in Michigan? Yeah. So you know the cold. You know the cold. When you go out in the cold, your body's going to have to respond to that. So being exposed to that cold, it's going to trigger organ 1 to produce hormone 1. Hormone 1 is going to go through the body and trigger hormone 2 to produce hormone 2. Organ 2 to produce hormone 2. That is going to stimulate our organ 3 to release hormone 3. Now we have that hormone going to the target cells of the body, which result in an increase in body temperature. Now that that's happened, we're going to have two things happen. Number one, this hormone 3 itself is going to downregulate release of hormone 2 and hormone 1. It's going back to the boss and saying, hey, there's plenty of me around. Stop sending signals for me to continue being made, right? That's number one. Number two, this increase in body temp is going to reduce the stimulus for hormone 1. Okay, so this is going to be a negative feedback as well. And so, does this system make sense? How we have all of these intricate organs working together to produce a change, especially in body temperature. Guess what? You just learned how the thyroid system works. Congratulations. It was just as easy as that. And so, when we talk about thyroid hormone, it all starts in the hypothalamus. This is the highest point of our brain. Hypothalamus is very important for detecting changes in big changes in our body status. So hunger, detecting our temperature, detecting how full we are. These really big changes in our status, hypothalamus is responsible for detecting that and initiating a change in our body to compensate for that. So when it comes to the cases of cold exposure, it releases something called thyrotropin releasing hormone that stimulates the release of thyroid stimulating hormone from the anterior pituitary. That goes through the bloodstream to our thyroid gland and stimulates the release of thyroid hormone. Thyroid hormone will increase the body temperature through increasing our basal metabolic rate. It also is going to have a negative feedback to the other organs to tell them to stop releasing so much of that hormone. Okay, very straightforward, very simple, and as how our thyroid works. Okay. So what does thyroid actually do? How does it work? Thyroid hormone has two forms, T3 and T4. T3 is the active form of thyroid hormone. However, T4 is more numerous in our bloodstream. It's not the active form, but it's the type that you would see in the highest volume in our bloodstream. T4 becomes T3 within cells. It's the active form again. Hyperthyroidism, overactivation of our thyroid gland. We see an increase in T3, but a regular T4. That's one thing we can look for. Some medications will increase our levels of T4. So methadone in our clients that are recovering. Oral contraceptives, estrogen, and clofibrate, which is a drug that we use to decrease our triglyceride levels. This is a drug that decreases our triglyceride levels in clients that have diabetes, hypercholesterolemia. Often they will have elevated triglycerides, so we can give clofibrate. However, that will increase our thyroid hormone. Other medications will decrease our levels of T4. So lithium, propranolol, this Inderal that we give for tachycardia actually decreases the level of T4, something to keep in mind. Interferon alpha, a hepatitis C drug, anabolic steroids, and methimazole is a drug that we give to treat hyperthyroidism. So obviously, if you treat hyperthyroidism, that will decrease your thyroid hormone. Okay? Any questions there? Levothyroxine, yes, so good. Levothyroxine is a exogenous thyroid hormone. And so rather than increasing levels of T3 or T4, it will behave as T3 or T4 and activate those same receptors. Okay, if that makes sense. So you wouldn't see changes in your T3 level. You wouldn't see changes in your T4 level. Rather, your levothyroxine is going to behave as if it is T3 and do T3's job. So in your hypothyroid patients, that's what it would do. Okay, excellent question. Good question. Okay, so this is a meme I added. You wake up hungry and you have to wait 30 minutes to eat after taking your thyroid medications. And this kind of gets to another sort of education thing for nurses and the NCLEXs. You have to let your patients know that thyroid medications cannot be taken on an empty stomach. Thyroid medications need to be taken after a meal to ensure proper absorption as well as to prevent damage to the gastric lining. So after you take your thyroid medications, wait 30 minutes to eat. Okay, you got to take it on that empty stomach. Okay, great. So hypothyroidism, lack of thyroid hormone. It can be primary from the thyroid itself just sort of not being able to meet the demands of the pituitary, or the pituitary itself, right? We talked about organ 1, organ 2, organ 3. The thyroid is organ 3, pituitary is organ 2. Having a deficit in either organ 3 or organ 2 can cause hypothyroidism. So a primary would be a problem in your organ 3. Secondary is a problem in your organ 2. And that is going to hold true as we talk about all of these different types of pathologies. Primary is always when it's affecting the organ itself. Secondary is when there's lack of stimulation from the higher level in the endocrine axis, essentially. This could be due to a surgical thyroid removal, some sort of irradiation, congenital defects, Hashimoto's thyroiditis, where you have a infection, a viral infection causing inflammation of your thyroid gland. A lot of different causes there. Symptoms are the symptoms of the lack of having thyroid. So thyroid hormone is very important for maintaining your basal metabolic rate. So it is going to essentially make sure that your energy is being used efficiently. So lack of thyroid hormone would cause a constipation, would cause a weight gain, weakness and fatigue. You could have some hoarse vocal sounds, some joint pain, muscle weakness, depression. These are all common things for hypothyroidism. The other big thing to look for is going to be cold intolerance. Cold intolerance. Because thyroid hormone is important for increasing our basal metabolic rate, we said that whenever it gets cold, the way the axis goes is we have organ 1, hypothalamus, triggers organ 2, our pituitary, triggers organ 3, our thyroid, triggers an increase in temp. Okay? Now, say we have some problem here or here. Now, whenever our client gets cold, as hard as the hypothalamus may try, there's no way to increase that body temperature. And so while you and I may be able to go out into, a 60-degree weather and say, it's not too bad out here, this is not too cold, that's really because we have this compensatory mechanism that's allowing us to compensate for the change in temperature. For someone who has cold intolerance, they're going into an even slightly cold area is going to be very difficult for them to handle. Okay. All right. So tests here, you can look for a decreased blood pressure, decreased heart rate, chest x-ray to look for any swelling of the thyroid, elevated liver enzymes, prolactin, and cholesterol. These all tend to be elevated in hypothyroidism through very complicated sort of mechanisms. These all go up when thyroid goes down. Obviously, decreased T4 levels will be there. Low body temperature, poor reflexes are these manifestations that you see in hypothyroid. Think of someone who's slow, who's cold, depressed, constipated, gaining weight, poor reflexes, cold skin, clammy skin. This is your hypothyroid patient, okay? Treatment for this, give them levothyroxine. You just got to increase those thyroid hormone levels. That's really your goal, is give levothyroxine. That is going to be a exogenous form of thyroid hormone we can give, which will bind to those receptors and improve some of those symptoms. Okay. So monitor for hyperthyroidism symptoms following treatment. You don't want to give too much levothyroxine. You want to give just the right amount. So watch out for hyperthyroidism. Heart disease, clients that are hoping to become pregnant should be warned that miscarriage is a potential problem here with giving levothyroxine. And if you don't treat hypothyroidism, your patient can actually enter a coma called myxedema coma. Okay. Questions on hypothyroidism? Pretty straightforward, right? For the NCLEX, really be able to identify your patient by the symptoms. Most of the questions that I've seen kind of are getting at, do you understand the difference between hypo and hyperthyroid in the realm of endocrine? Okay. Great. What sort of things are these clients going to need? They're going to want blankets. We need to watch their blood pressure, watch their heart rate. These are the sort of the things that you want to look out for your exam. For hyperthyroidism, now we have excessive production of thyroid hormone. And I put this gentleman here really watching and making sure you're taking notes on this slide. Okay. So causes of hyperthyroidism and iodine overdose. Thyroid hormone essentially is just a bunch of iodine that is stuck onto a protein. And the iodine is what's going to cause activation of the receptors. So any iodine overdose of thyroid hormone, your levothyroxine, can lead to hyperthyroidism. Graves' disease is an autoimmune disease where the body starts stimulating those TSH receptors. The TSH receptor. The TSH is that connection. Here's organ 1, organ 2, organ 3. TSH is what's being released from organ 2 to bind to organ 3 to cause release of your T3 and T4. And so in Graves' disease, what happens is your body starts attacking these receptors, and rather than destroying the receptors, it turns them on. It activates them. So now we have vastly increased levels of thyroid hormone. And the treatment for that would be to take out part of the thyroid gland or to medically destroy parts of the thyroid gland to prevent too much thyroid hormone from being released. Symptoms here. Let's think about the opposite of a hypothyroid patient. So let's think about weight loss. Let's think about anxiety. Let's think about an increased basal metabolic rate leading to sweating, nausea, diarrhea, skin color changes. These clients are going to be intolerant to hot temperatures. And so while you and I can go out on Miami Beach, go out onto that 102-degree sand, hot sand, really beautiful, and we might feel a little bit hot, but we're not going to be, oh, this is too hot for me, I have to run back inside. Our body will be able to compensate for that heat and start to sweat, start to dissipate some of that heat because of our regular levels of thyroid hormone. If we have too much, then when we go out in that heat, we won't be able to compensate for that heat, and we're going to become intolerant. So instead of going out on that 102-degree beach and maintaining a normal temperature, so if you and I go out onto a Miami Beach, it's 102 degrees outside. If you look at our core temperature, it's still 98.6. For these clients, when they go out on that beach, their core temperature is going to be going up to 99, 100, 101. They cannot modulate their heat. So they are heat intolerant. And we can look for sweating, elevated BP. And last, we can look for something called exophthalmos. And so this is the real reason I put this gentleman on this slide, so you can see what exophthalmos looks like. And so ultimately what happens is thyroid hormone is going to cause growth of the fat cells that are behind our eyes. There's fat that is all around our eyes. And because our eyes move around quite a bit, fat provides a nice source of energy for our eyes and those muscles that are there to always have energy to keep looking around. If those fat cells are stimulated to start growing, it's going to push on our eyeballs and push them out of our head. And ultimately, they're going to pop out and roll on the floor. Just kidding. That doesn't happen. They're just going to kind of have this protruding appearance. And ultimately, you have to surgically go in and take out some of that fat. Unfortunately, these patients do have to have surgery to repair that. So the tests we can do is an elevated systolic pressure. Obviously, look for those levels of thyroid hormone. If it is a primary issue where this organ is affected, you should see decreased levels of TSH. Why? Negative feedback, buddy. Negative feedback. This thyroid hormone is telling this pituitary to stop making TSH. Okay, so your TSH level should be low and your thyroid hormone should be high. That make sense? Yeah, great. Radioactive iodide will be taken up by your thyroid gland and actually destroy parts of your thyroid gland. And so our thyroid kind of has this H look in the neck, right? So when you give radioactive iodide, you're not going to completely kill off the thyroid, but you may take out maybe like 75% of the active thyroid, so you only have 25% left. And that 25% ends up giving you just the right amount of thyroid hormone because you have Graves' disease. You can do surgery to remove some of the thyroid hormone, as we mentioned before. One of the complications or side effects of beta blockers are that they reduce levels of thyroid hormone, right? We mentioned that before. And so beta blockers can be used to help with these patients, as well as anti-thyroid drugs. Some of the most common ones that you'll see are methimazole, which we had written on the slide earlier, methimazole. And another one is PTU. These are both drugs that will go into the thyroid gland and prevent production of thyroid hormone. Okay. Questions on hyperthyroidism? PTU. Yeah. The full name is, and I was trying to think of it. It's like, man, I can't remember the full name of it, but typically you'll see it written as PTU. Let me look it up really quick, actually, just so I can tell you, so you have the full picture here. PTU. PTU is propylthiouracil. So let me spell that out. Propylthiouracil. Okay. So both of these are very good drugs to give for your patients with hyperthyroidism. The only issue that you want to watch out for with PTU is that for your pregnant women, they should not take PTU. They should take methimazole for pregnant women. Okay. All right. That's sort of the most high yield thing I can tell you about those particular drugs. All right. Let's see. So Graves' disease, we mentioned before. Autoimmune disease, we're looking for that exophthalmos, the eyes protruding out. Symptoms here, elevated appetite, everything for your hyperthyroidism you would see here, right? Because this Graves' disease is a type of hyperthyroidism. Elevated heart rate, elevated T3, T4, decreased TSH. You can see a goiter or a swelling of your thyroid gland. We can use all the same treatment strategies as well as add in prednisone. Adding in a corticosteroid helps to reduce our immune system because this is linked to an autoimmunity. Reducing the immune system means we're going to reduce the symptoms. Okay. Keep an eye out for fatigue, congestive heart failure, depression, as well as hypothyroidism when we give too much. Okay, so just keep in mind that autoimmune linkage. Autoimmune diseases tend to be more common in women, you'll see, and so that's one other thing to know is whenever you're seeing these autoimmune diseases, the picture in your mind should typically be a female. Alrighty. So great. So next time we meet, we're going to start talking about adrenal glands. There's some complicated things in adrenal glands, especially talking about our Cushing's disease. This picture we're really going to go over in depth because Cushing's disease is a little bit complicated.